All right, so hello everyone. It's so good to see you guys back. Um, my name is Dr. Pausar, and you're watching MedReader. On today's topic, I want to discuss something very miscellaneous that is tested on the ABIM boards. Is understanding what is bailout during a PCI procedure. So let's actually get started with a question. So you have a 62-year-old man who is presenting to the emergency department 2 hours of substernal crushing chest pain. His EKG showed ST elevations in lead V1 to V4, and he's immediately transferred to a PCI cath lab. He receives aspirin, P2Y12 inhibitors, and therapeutic unfractionated heparin. His angiogram showed 95% thrombosis of proximal left LAD. Following balloon inflation, repeat angiogram showed a persistently slow TEMI flow of 1 with heavy intracoronary thrombus burden and microvascular no-reflow despite having adequate ACT time. So what is the most common intervention you're going to do? Start them, give them a bolus and infusion of Eptifibatide, which is a GP2B3 inhibitor, administration of a routine upstream intracoronary TPA, escalating to high doses of unfractionated heparin, DC the P2Y12 inhibitor, and transition to IV Candida prophylaxis, immediate referral to CABG surgery. So the correct answer here is going to be IV bolus infusion of as well as continuous infusion of Eptifibatide for a couple of hours, and that's where the whole concept of bailout therapy originates. So understanding bailout in PCI is relatively a miscellaneous topic. We don't hear about that much, but that's something that's going to be, that the cardiologists are going to be doing on your patients who are getting a stent, so you should be informed about the same. Okay, so what is a general definition of a PCI? We all know that patient presents with ACS and you do a certain standard of care, which includes providing them with aspirin, you provide them with Plavix or Ticagrelor, and putting them on heparin drip, getting EKG, and consulting your cardiologist. Now, when the cardiologist is doing a cath or a PCI, and their goal during that time is to rapidly restore an epicardial TEMI-3 flow of the blocked vessel and prevent any catastrophic stent thrombosis, for which we do continuous PCI, dual antiplatelet therapy, for a couple of months to a year. Now, where does the bailout come in? So in context of bailout, there's medicine called Eptifibatide, Integrilin, which can be used as a bolus and also as an infusion. It's a GP2B3 inhibitor, and in true senses, it just means that you're starting this medicine because you saw some complications while doing the cath. It can be an extensive large thrombus, it can be a distal embolization, microembolization, which does not let you achieve good flow, TEMI flow, or it can be due to other major complications like dissection. Anything that is obstructing your coronaries and you're not able to achieve flow, you can consider this. Obviously, there are some other complication which needs to be addressed, but especially for someone with large thrombus burden, not being able to achieve a TEMI flow, you quickly fix them with like stenting, but still, this way you need to start them on this drip. Okay, so what constitutes bailout in PCI? Abrupt vessel closure, as I discussed, some of the complications like dissection, like microdissections, forming of a new thrombus upon a previous one which was stented, distal embolization and achieving no reflow phenomenon because of that, or a slow flow because of a high thrombus burden. You can use these. That's considered bailout, and you can use the Eptifibatide drip in that case. So what are the guideline recommendations and scenarios from the ACC/HA SCAI? They have kind of like compiled it into a Class IIa level of evidence of when to use it, and a Class III recommendation of when not to use it, and when is it considered harm for the patients. So let's go over those. So Class IIa reasonable recommendation to start Eptifibatide in those patients who have ACS and during their angiography or PCI procedure, it is discovered that they have a high thrombus burden or they have no reflow or slow flow phenomenon. In those cases, it can be considered case by case. The class 3 harm is when you have an ACS patient but no such complication is occurring during the PCI procedure, then administering that, administering the Eptifibatide in those cases has more harm of bleeding than providing any real benefit. And obviously for your stable ischemic heart disease patient, for which you're doing in under elective PCI, there's no role for Eptifibatide in those cases. You can continue them on the DAPT therapy, which is again standard of care. Right, so this image is kind of giving a good view of how a large thrombus can obstruct the flow. Imagine if the top image, you have a stent before that, but just because how large the thrombus is, based on the IVUS technology, you're not able to see, good patency of the vessel. You can consider this bailout regimen in those cases. Or if you have like small microemboli that goes distal to that large vessel and causes a slow flow phenomenon, in those cases also we can use the bailout strategy and start them on Eptifibatide. These were some clinical trials that you can refer to regarding some benefit that was seen in cases of complicated PCI that we discussed, and use of Eptifibatide was encouraged in these trials, or showing benefit. Alright, so these are some of the dosing indications for both patients with normal renal function and renal impairment. So remember, if they have renal impairment, you can still use the boluses, but the slow infusion rate is gonna be 50% lower. So 180 microgram per kg IV is the first IV bolus that you should use pre-PCI. And then you continue the infusion at 2 mcg per kg per minute IV, and let it run at least for a minimum of 12 hours. The whole window is 18 to 24 hours. And during these time, when the patient are on these drips, you will need to monitor that CBC, especially platelet count, and physical signs if the patients are having any new onset of bleeding, or a prior bleeding that is getting worse, or something like that. There is also a target ACT with unfractionated heparin you must be achieving. It's 200-300 seconds. Case by case, it can differ. So refer to that for more details. So really, just the absolute endocrine contraindication is creatinine clearance of less than 15 per minute, or the patients who are on hemodialysis, because these are going to be, your patients in whom you'll need to consider other alternatives, and risk versus benefit of bleeding should be considered. Its half-life is 2.5 hours. It's not that bad, and platelet function recovers within 2 to 4 hours after discontinuation. So fast recovery compared to Epsiximab. So Eptifibatide, Integrilin is used for those purposes. Alright, so some of the lab monitoring and safety points you need to check. A mandatory pre-infusion lab includes a baseline hematocrit and hemoglobin, a platelet count, serum creatinine, PT, PDT, and ACT when you're dealing with cath lab patients. You need to check platelet count every 2 to 6 hours until the infusion is finished to catch for early acute thrombocytopenia, because that's the most well-known effect or the side effect of these medicine. Intracoronary versus IV. IC bolus delivers high local drug concentrations at the thrombus site. Clinical trials, although, have shown similar efficacy and safety for IC versus IV routes, so it doesn't matter. Higher bleeding risk, patients who are above 75, female, those with CKD stages 3 or more, just because of the clearance of the drug is impaired, anemia or prior bleeding, all these are some of the considerations to, that might hold off the use of this therapy. Early sheath removal is essential, as I mentioned, because it comes with bleeding risk, and avoid post PCI heparin infusions if you are on Eptifibatide. So that's also one way of reducing, once you put the stent in and you had this complication of low flow, you start Eptifibatide, you can consider holding back on heparin to reduce the chances of bleeding. So key clinical takeaways out of this: bailout is only used in specific cases where you have PCI that might be complicated by large thrombus or no flow or slow flow phenomenons. Use it, start with boluses, and use the infusion based on the renal function of the patient and continue it for at least 12 hours. Get platelet levels every 2 to 6 hours just to make sure you're not going into thrombocytopenia. And you can always give platelets if that happened to the patient. Check the creatinine clearance first before you start this medicine, because as we discussed, we need to cut the infusion rate to 1 mcg per kg per hour. Usually 2 is recommended, but cut it to 1 if your creatinine clearance is less than 50, and watch for bleeding as we discussed. Alright, so that's pretty much it. If you liked or enjoy this video, then please subscribe to my channel, and that's gonna give me some support, and see you in the next one.